All right. Good afternoon, everybody. I am Archana Vyas, Deputy Director for Communications and Behavioral Insights at the Bill and Melinda Gates Foundation. On behalf of BMGF, UNICEF, Tarang SBCC Hub, New Concept, and WeCan, I welcome you all to the webinar on Solid Body, Smart Mind, Demand Generation for Anemia Mukt Bharat. I would also like to take this opportunity to introduce my co-hosts who've been providing all the support and facilitation of this webinar and who have really worked behind the scene to make this and hopefully a successful webinar today. Rachna Sharma from UNICEF, Sudha Nair and Sohini Chaudhary from New Concept, Dr. Alok Ranjan, my colleague from Gates Foundation, Novina Swapna and Anumeha Varma from WeCan. We all are particularly delighted to host this webinar in this significant moment of World Breastfeeding Week. We know from data that there is high prevalence of anemia amongst women of reproductive age and pregnant mothers in India, over 50%. And also that we know that beyond supply interventions, which are used in plethora, behavioral interventions can really spur demand. We know that behavioral interventions can be successful in accelerating IFA tablet distribution, their adherence, consumption, and also uptake and intake of iron-rich food. I'm hoping that today's deliberations and discussions will bring out not only what, but also how to do and how to increase consumption and adherence that I've spoken about. For this, we have a very rich panel of experts. I am welcoming all of you. Thank you so much for your time. Some of our experts are also joining from outside India, so this is really, really odd time for them. I am deeply appreciative of everybody making time for this webinar. And thank you so much for audiences as well for joining today. We have Dr. Seela Deb, who's Additional Commissioner, Child Health and Nutrition Expert from Ministry of Health. We have Siddharth Shresht, who's Chief of C4D from UNICEF. Deepika Chaudhary, who is a Senior Health, Nutrition and Population Specialist from the World Bank. Preetu Mishra, who's Nutrition Specialist from UNICEF from the state of Jharkhand. Dr. Rajiv Rimal from the Johns Hopkins University. Daya Shankar Singh, who's C4D Officer from UNICEF UP, and Dr. Pawan Mimadi, who is Director for Center for Social and Behavior Change at Ashoka University. Since we are more than 100 participants, I'm sorry, unfortunately, you'll not be able to introduce yourself, but thank you and welcome to all of you. Thanks a lot for joining this webinar today. Quickly, some general housekeeping rules. You know that today's participation in this webinar is scheduled for 2 hours. It is from 3 p.m. to 5 p.m. We will take some question and answers. I'll be asking some questions of the panelists after their panel. You can also ask questions. Please press on an icon which shows a raised hand, which is at the bottom of your screen, or you can share your questions, comments, as well as feedback in the chat box, which is on the right end of your screen. All the co-hosts are able to view your comments and feedback. They can take your comments and feedback and address them as they speak, but you can also, we will also be looking at your questions, and you will have an opportunity to, some of you might have an opportunity to ask questions. And if you are provided with that opportunity to ask questions, please keep your introductions very brief. Speak about who you are, which organization, and come to the question straight away. And please keep your questions short. We want to give everybody an opportunity, many of you, to ask questions. So please keep it short. If you're not able to take all those questions, we will collate all of these, and answers will be provided by our experts, and they will come to you in the summary of deliberations, which will be circulated after this meeting. The moderator has turned off videos and also muted your mic, so don't worry. It's not like we don't know you, that you're there. You're pretty much there. We know. So please keep putting in your feedback and comments and questions in the chat box, please. The meeting is being recorded. This is going on Facebook Live as well. If you have any reservations, please come back to the chat box and we'll look at that. I want you all to know that the presentations are available on the Anemia Mukt Bharat dashboard. The team has done a phenomenal job of putting together this dashboard. So please, you will be able to access, no need to write out any notes, but you will be getting access to all the presentations through this phenomenal dashboard that has been put together. I'm not taking on so much of time right now. This is all for the panelists. This is all the time for you. So first of all is coming up an introductory remark, our first panel. I'm inviting Dr. Sheila Deb, Additional Commissioner, Child Health and Nutrition from Ministry of Health, been working with the Ministry of Health and have extensive experience as far as a child health and nutrition program. And you can read the bio yourself that she has extensive experience. So over to you, Dr. Deb.
Thank you, Archana. And a very good afternoon to all the panelists and the participants of this webinar. And first of all, I thank UNICEF and BNJ and all the other supporting partners for organizing this very important webinar. As you all know, that anemia in India is a severe public health problem, and it further increases the risk of morbidity and mortality, especially for the pregnant women and in the young children. And the prevalence of anemia is also high because of the poor compliance with the IFS tablets what we have in the form of a program, and also there is inadequate dietary intake. So as we all know that 50% of all anemia, they are due to the nutritional causes. And that's why we have had this IFS supplementation program for long. But to strengthen this program, we have now had this Anemia Mukt Bharat program, which is a 6x6x6 strategy. And these strategies, one of the key interventions is to intensify the year-round behavior change communication campaign, that is Solid Body Smart Mind, we call it. So at present, for this anemia campaigns or as a communication strategy, we have the test and treat and talk approach. And this is the only platform where awareness on anemia and information on nutritious and iron-rich diet is being provided to the masses. Also, various resource materials for awareness and demand generation are available in the form of material for interpersonal communication and also for media on the AMB dashboard portal. And this is for the utilization by all the states and other development partners. However, with the advent of the advanced technology reaching the masses with desired information has become relatively easy, and especially this is the situation of the COVID-19 pandemic. So here, though we have all these strategies for social mobilization and demand generation activities, which can be carried out at different levels, such as radio and TV talks and leveraging social media platforms, radio spots and jingles. But I stress that we must use this digital platform maximally. So the messages on awareness generation, it can be customized to the context, and it should be made available to the masses in the most accessible and penetrative medium. So I request all the development partners who are engaged with us for this Anemia Mukt Bharat strategy, and all the technical support partners and other organizations to please come forward to provide mentoring and hand-holding support to the frontline workers so that they can deliver better and efficient services at large. So I am confident that the expert deliberations in today's webinar will provide new ideas and approaches which may be more effective for demand generation activities in view of this COVID-19 pandemic situation. So thank you. Thank you, Archana. Over to you.
Thank you so much, Dr. Seela Deb, and we take your guidance and so much of it is so important to look at this program, especially during the COVID times. Next, I'm going to invite over Siddharth Shresht. He is the C4D chief from UNICEF. As you can see, he is an MBA from Kathmandu University, but he is leading a very, very important portfolio of communications and behavior change at UNICEF, which spans across all the program priorities of UNICEF. So over to you, Sid.
Thank you very much, Archana, and thanks, Dr. Sheila Dev. Good afternoon, everybody. Partners and participants, or rather I should say nutrition champions, because if you are not, then you probably wouldn't be here. It is indeed great to see this webinar being organized with the joint effort of so many partners who I am pleased when I look at the names and the logos there are all part of the National SBCC Alliance. Now, coming to the webinar of today, when we look at successful social development programs, we notice one thing in common. And what is that? It is, of course, social and behavior change communication is an integral part of whether we talk about the design, whether we talk about implementation and monitoring. You know, some examples which we can see in the past is the polio eradication campaign, the HIV/AIDS prevention campaigns. All of them, you can see SBCC was a key part of that. Much appreciation goes to the Ministry of Health and Family Welfare for integrating demand generation agenda as one of the key 6 strategies of Anemia Mukt Bharat. This program, of course, has a large responsibility, as 2 out of the 5 goals of Poshan Abhiyan hinges on this program's success. The tagline, solid body, smart mind, clearly communicates the benefits of living an anemia-free life and comes loaded with a comprehensive communication resource toolkit, which Dr. Sheila Dev also mentioned about jingles and the number of communication packages which has been done across the board. And it is, of course, readily available in the public domain. I want to go a little bit back to the States. When we look at AMB work in the States, it is definitely truly encouraging to see so many examples. And as we say, action happens all there in the States. I'm looking forward to experiencing the state examples in this webinar from the agenda we see, from budgeting for demand generation to behavioral insights and social norms. Some aspects and lessons learned coming from the States I have been privy to and believe to be important there are 3 of them which I just picked up. One is definitely convergence. Convergence is a keyword coming across the key line departments. Health, WCD and education, which has laid a strong, solid foundation in some states and is a clear path to success, because one department for AMB is not enough. There needs to be a concerted and a convergent approach from all departments. The second one, very important, particularly for all types of implementation, is the advocacy part. Advocacy with special reference to increased resources in the states where budget allocation for SBCC under the AMB program has increased by almost 100% in some states and over $300,000 in another. Surely a good example of leveraging resources, because we can talk about a whole number of strategies, but without proper financing in the PIPs, we cannot do what we plan for. The last one being from an equity perspective, I think it's very important to also talk about various other communities. And here I give an example of the tribal communities in Odisha, where intensive community engagement programs with the self-help groups, the local faith healers and adolescents in government-supported Sampurna program, as they call it there, has indeed gone a long way in improving IFA consumption, especially in some key areas where SBCC works, to bust local myths. That there is a myth there saying that if Having iron will foster faster growth in the baby and will be difficult for normal delivery. So that's where the job of SBCC is there, to bust these local myths so that people are aware of the right things to do. One of the highlights for me for this AMB program is the 3 T's camp, 3 T's camp, which all of us, I guess, right from the participants to the panelists know about. The test, treat, talk, which increased high levels of awareness. And it was why? Because it was a very simple and effective call to action. When we talk about 3 T's, doesn't it remind you of the current pandemic, COVID-19? Of course, in this case, the 3 T's in this case is trace, test, and treat approach, which is the mantra being used by almost all countries, as it has helped a number of them control this virus. For RCCE, or risk communication and community engagement, we can add talk, as we can easily equate that to communicating effectively or even counseling. RCCE is one of the key response strategies for the pandemic, and the behavior change practitioners, guess all of us here, have been exploring the narrative of reimagining SBCC, and there's been quite a few webinars already done in this regard. So adding a 4th T, the talk one, could be an example of reimagining SBCC, the talk or the counseling part of it. Now, coming to the experience in the current context, digital tools and engagement has never been used so extensively, as we all know, for SBCC and demand generation. And the same applies to the Anemia Mukt Bharat program. It has been optimized right from capacity building, training over 400,000 frontline workers in record time within a period of 2 weeks, to implementation using a variety of tech platforms like WhatsApp, Telegram, UReport. What is interesting in this case is the experimentation going on in this context. For instance, if you look at WhatsApp, communication materials were not just sent, but follow-ups were ensured to support the workers, and still does. Of course, it's an exploratory process. There are some hiccups there, but that's going to the next level using technological platforms is what I'm talking about. Adolescents and youth engagement through the NSS, Scouts and Guides got institutionalized in some states during the pre-COVID days. And this is definitely paying rich dividends in tackling the current pandemic. When we look at interpersonal communication, it is being used wherever possible in communities, but largely to a limited extent. And you know why? Due to a lot of social distancing measures, which is one of the key preventive behaviors for COVID-19. Knowledge management is another area which is really picked up in the current context. The series of webinars like this current one, with practitioners, experts, researchers, so that the discourse, the direction on social and behavior change communication is maintained and still going strong. In summing up, I wanted to leave you with a few thoughts of mine of how do we leverage the COVID RCCE response with AMB, Anemia Mukt Bharat demand generation. We know there is a lot of pressure for the AAAs, the Anganwadis, the Ashas, and the ANMs to deliver on all fronts. So, there is a lot of pressure to work on the normal aspects of it, right from demand generation for routine immunization, nutrition, wash priorities. So that's where I think, how can we reimagining, strengthening the peer-to-peer approach for adolescents so they themselves become mobilizers, trainers, and change agents for nutrition. It's not that they have not been doing it, but can we look at innovative ways of strengthening the peer-to-peer approach is what I was talking about. And anyways, as you know, they are being supported, adolescents are being supported to continue counseling activities with social distancing, masks, and other protocols. And when we talk about the digital engagement space, which I was touching upon just a few moments ago, they can be valuable in also supporting the work of our traditional frontline workers, be it capacity building or social mobilization. One thing, however, to note is to explore and implement the hybrid approach of we have the digital engagement here and the real-time community engagement where possible, because there is, as we know, a digital divide, and we can never ever discount the power of face-to-face communication and counseling. And finally, I encourage the ministry, organizers and participants here today to play your part and not let the gains of Anemia Mukt Bharat demand generation slip, as the SBCC journey still is to be continued. Thank you. Over to you, Archana.
Thank you so much, Sid. So, Sid has spoken about reimagining the entire approach to demand generation for Anemia Mukt Bharat through peer-to-peer approach, leveraging digital technology, and not letting real-time monitoring being offline versus digital technology. So thank you so much, Sid, for those remarks. And now we are getting into a first panel that focuses on budgeting for Anemia Mukt Bharat demand generation. I am requesting our panelists to join in. Can we have the bios, please? Bios are coming up. So the next panelists of ours are Deepika Chaudhary. She is Senior Health, Nutrition and Population Specialist from the World Bank. A few words about Deepika. She is a senior specialist and not only working in India, but also in Afghanistan, Bangladesh, and Yemen on the programs of health and nutrition. She's got 20 years of experience in maternal and child nutrition and health, both in technical and managerial capacity, and has extensive knowledge and technical expertise in these areas, working across geographies. She's a PhD in public health nutrition from AIMS and has several publications to her credit. Requesting Deepika to take on and let's have a presentation on for her to share her thoughts in terms of budgetary allocation.
Thank you, Archana. Good afternoon, everyone. It's a pleasure to be on this webinar today on this very important subject. So at the outset, I would like to thank the organizers for providing the World Bank this opportunity to share our perspective on the role of the Poshan Abhiyan in demand generation for a Anemia Mukt Bharat. Next slide, please. Many of you are aware that in March 2018, the Ministry of Women and Child Development, Government of India, launched the Poshan Abhiyan to reduce undernutrition through a life cycle and result-oriented approach to reduce stunting in children, reduce anemia among women and adolescent girls, and to reduce low birth weight. This program is operational in all states and union territories of India. The key approaches for achieving nutrition impact during the critical first 1,000 days of life under this program include capacity building of Anganwadi workers on nutrition counseling, community mobilization and behavior change communication, which is also called the Jan Andolan strategy, use of a mobile-based information technology tool called the Integrated Child Development Services Scheme Common Application Software for improved monitoring and management of services to facilitate better outreach. Performance-based incentives to Anganwadi workers for service delivery, and convergence with other sectors, which include education, agriculture, rural development, and water and sanitation, among others. The first two strategies, that is capacity building of the frontline workers and the Jan Andolan strategy, are directly related to the social behavior change communication for demand generation. Next slide, please. The focus of the Poshan Abhiyan is on maternal and infant and young child nutrition, and each of these messages that you see listed in the slide contribute to the reduction and prevention of anemia in women and children. These include more specifically promoting consumption of iron folic acid tablets and dietary diversity during pregnancy, and early and exclusive breastfeeding and appropriate complementary feeding during infancy and childhood. Therefore, clearly, the Poshan Abhiyan plays a significant role in contributing towards demand generation for a Anemia Mukt Bharat. Next slide, please. The Jan Andolan framework consists of a well-planned strategy which includes interpersonal communication, mid and mass media activities, and intensive campaigns called the Poshan Ma, conducted during the month of September, and the Poshan Pakhwada, which is conducted for a period of a fortnight. The activities include prioritize home visits, community-based events, which includes celebration of pregnancy to promote appropriate nutrition practices, and also the celebration of a child turning 6 months to introduce complementary feeding, folk and print activities, radio and TV spots, school rallies, and others. Next slide. Here are some examples of the specific messages and materials that have been used under the Poshan Abhiyan, be it a flip book for interpersonal counseling by an Anganwadi worker with the beneficiaries, cartoon radios, TV spots, also converted to radio messages, and the print with very specific messages which contribute to anemia prevention and reduction. Next slide, please. Now, when we look at the budgeting for the social behavior change communication in the Poshan Abhiyan, earlier under the Integrated Child Development Services Scheme, there was only one line item, which was information, education, communication at the Anganwadi Center in the budget planning framework. However, now, under the Poshan Abhiyan, there's been a major shift, and there is a budget line for Jan Andolan strategy, or the social behavior change communication. There is an allocation broadly of rupees 19 lakhs per district annually in every state, and the annual plans are being developed at the state level based on the Jan Andolan framework, which I just showed you, which focuses on interpersonal communication, mid and mass media activities. In addition to this allocation, there is also rupees 250, which is allocated for conducting every community-based event in each Anganwadi center, and each of the centers has an allocation of conducting 2 community-based events every month. The current experience, particularly in the priority World Bank supported states, tells us that the budgets are primarily being utilized for the Poshan Ma and the Poshan Pakhwada activities over the last 18 months, and more variably for other interpersonal communication and mid-media activities. Having said that, in terms of a very specific line item for Jan Andolan, there are also other opportunities for interpersonal communication through the use of the ICDS CAS tool, which I mentioned earlier, which is for monitoring and service delivery, which can be utilized for messaging and communication. There is also an electronic incremental learning platform, which is a part of the Abhiyan, which helps create demand. And these are, of course, budgeted beyond the social behavior change communication budget codes. So overall, there has been a phenomenal movement in terms of prioritizing adequate allocation to begin with on the different activities under the social behavior change communication, or the Jan Andolan strategy of the Poshan Abhiyan. So while the Ministry of Women and Child Development and the Poshan Abhiyan was still assessing and intensifying the Jan Andolan strategy, we found ourselves in the midst of the COVID, which has changed the architecture of the Jan Andolan, as was being outlined. The campaign type activities and gatherings with people have come to a halt, which was the mainstay of the campaigns. And this has primarily come to a halt to prevent and control the spread of the virus and to adhere to all the norms that have been laid out in terms of protocols to contain COVID-19. Now the format is changing to the use of short text messaging, telephone calls, video calls, WhatsApp groups, etc. for nutrition counseling. Use of home visits also continues, primarily for the purposes of messaging and to some extent counseling, although it is variable. And home visits are being conducted in a mandatory manner to distribute take-home rations at the doorstep of the beneficiaries as a part of the Ministry of Women and Child Development COVID-19 guidelines. So that opportunity does remain. In this slide, you can see that the Anganwadi workers remain a major frontline workforce in each village in terms of communicating at the community level, at the household level, with pregnant and lactating mothers and supporting them with information, messaging, as well as problem solving. Next slide, please. So in summary, the Poshan Abhiyan, which is a flagship nutrition program of the Government of India, has a very sharp and explicit focus on social behavior change communication, hence demand generation. We have reviewed that it invests in promoting maternal and infant and young child nutrition, which contributes significantly to anemia reduction in women and children. We also find that as compared to the earlier ICDS, there are specific budgets that have been earmarked for social behavior change communication. Planning, of course, can be better defined and refined in the budget planning framework. There is scope of improvement, and so does implementation have the scope to be better streamlined and intensified. As all of you have already laid out, all of this now needs to be viewed in the context of COVID-19, which is going to have an impact both on future budgetary allocations and the related expenditures over time. Thank you. Over to you, Archana.
Thank you so much, Deepika, for your thoughts, and I will come back to you with questions. So please don't go away. Let your video be on. You can go on mute while I invite our other panelists. Can we have Pritu's bio, please? And I realize that there is a Q&A chat box available as well. I encourage you to look at those, to use Q&A for posting your questions. We do have one question that has come up, and we will use your questions at the end of the session. Now I'd like to welcome Pritu Mishra, who is a nutrition specialist from UNICEF Jharkhand. She holds 2 master's degrees, not one, but 2. One in health administration from TIS Mumbai, and the other one is in public health nutrition from University of Baroda. And she's extensive, again, you can see from her biodata, she's got extensive experience in work in health and nutrition areas. Very, very thankful for Pritu to join in. Pritu, can we have your presentation, and please share your thoughts on importance of budgetary allocations, especially your experience in the state of Jharkhand. Looking forward to hearing from you. Thank you. I will utilize this time to ask some questions of Deepika. Deepika, you're not going away. Quickly wanted to ask you, you had spoken about the issue of, I'm looking at my notes, refinement of budget planning Can you talk a little bit more about that?
Thanks, Archana, for the question. So while we do have a Jan Andolan framework and we also have the Jan Andolan guidelines, when we look specifically at budgets, and as you know that the state government functionaries are very operational and want sort of clear guidance and instructions coming down for them to plan. The budget planning frameworks are not as specific as they should be. They are still broad-based. So the planning is done as per, just the overall guidance from the Jan Andolan framework. What I specifically meant was there was no specific guidance as to how much of that allocation should ideally be spent on IPC, vis-a-vis mass media, vis-a-vis Poshan Ma, etc. We are finding that extensive amounts of money, which has been overall, which is an overall allocation for the year, is getting spent for example, in the September month. So,
Right.
There is a plea for further refinement of the budget planning framework,
Right.
so that the states have more specific guidance to plan better.
So that's
Over.
fabulous. So you're basically talking about further refinement in the sense disaggregation of budgets. We know what's working and what's not
Sure.
working, and therefore allocations accordingly.
Yes.
Which to my mind is extremely critical, and that's very, very important and pertinent point that you make. And my next question, I don't know whether we've got Preetu back. Preetu, can you say something, or I'm going ahead with my second question to Deepika, and I will continue to ask. Oh yeah, we've got. Yes, you are audible. So let's have Preetu's biodata back in. While that's coming on, I'll let you go away, Deepika, with one last question, and then we can have Preetu back. You think that such budgetary allocations are happening for the Jan Andolan component? Do you think such refinements? One, of course, they are possible, but the upcoming, Jan Andolan and Poshan Abhiyan, such refinement is going to be happening within the, the upcoming current budget allocations.
Archana, we are not aware as the bank in terms of any recent discussions that have happened in refinement of the budget planning vis-a-vis Jan Andolan.
Right.
We know that the ministry is planning for the forthcoming Poshan Ma, but we are not aware of any refinements in terms of giving that specific guidance to states is coming forward. But it could be that other partners would be aware. We are not aware, but any efforts and discussions which we are also going to have in our forthcoming implementation support mission for the Poshan Abhiyan, this would be a point of discussion, but nothing specific so far to share with all of you. Over.
But yeah, thank you. And it's really heartening in terms of how the government has allocated budgets, and even, budgets have been assigned for each of the activities, and you're playing a critical part supporting the government with the Poshan Abhiyan and the health and nutrition program. So thank you so much, Deepika, for sharing your views.
Thank you,
Preetu, now
Archana.
that we have, thanks. Now that we have you back, Preetu, over to you to speak about your experiences coming in from state of Jharkhand.
So I'll quickly come to my presentation. Thank you so much for this opportunity to Jharkhand. And in my next few slides, I'll be talking about the story from Jharkhand and the leadership that the state government provided, especially from the health sector. So coming directly to the budget, Jharkhand received around 2.6 crore rupees dedicated to AMB demand generation. Overall, there was a 26% more budget that Jharkhand state received, and especially for IEC BCC, there was a multifold increase. So the story that I'm going to share in next few slides is basically how Jharkhand state moved ahead to getting nil budget in 2019-20 PIP to getting nearly 2.6 crore rupees for the present PIP approval, which is 2020 to 21. Next slide, please. Here I would like to first say that government of Jharkhand is very much committed for improving anemia prevalence, and which is very clearly reflected from the proposal that was sent from the state government to ministry that had proposal of around 50 crore rupees dedicated to Anemia Mukt Bharat. Demand generation is a very important pillar of the 6x6x6 strategy that Dr. Sheila Dev was also mentioning. And while this program is a very procurement heavy and distribution heavy program as well, because there are a lot of IFA formulations involved, albendazole and other things. However, the supply and demand needs to go hand in hand for improving the coverage, compliance, and overall impact in the nutrition indicator. So when we started in Jharkhand, when we started discussing on what to have for demand generation for AMB, there were a lot of questions and queries in our mind. What to budget? What exactly do we mean by an ideal SBCC strategy with components and budget for Jharkhand? We know that only printing IEC material is not equal to demand generation, but there are softer parts which are involved along with the material to transact the messages, resulting into improvement of social behavior change communication. Where to budget? So if we see the national guidelines, it clearly rules out that there is a dedicated FMR code, which is FMR code number 11 for ICBCC, but even under that, there are so many minor heads, and it was even a question within us where to budget, because Anemia Mukt Bharat rolls across divisions, and it's not only a child health program. Usually a child health DD is the Anemia Mukt Bharat nodal officer, but we know that Anemia Mukt Bharat components is across child, adolescent, maternal, family planning, non-nutritional components like fluorosis, vector-borne malaria, and of course ICBCC cells. So another question was how much to budget, because a lot of new things were there, a lot of materials was available, but we didn't have the cost norm, we didn't have any standardization. So while a lot of material was available, which to pick, which not to pick, there were a lot of questions. And lack of standard cost norms were one of the biggest challenges that we found, especially in 2019-20, the previous PRP. Next slide. So in this slide, I will briefly share about what 10 to 12 steps that government of Jharkhand together with partners adopted to ensure that we have enough funds available to ensure that there is a demand within the community for services available under AMB program. It required first to deep dive on the technical assistance, even within partners as well as within government, to improve the planning and allocating efficiency for the nutrition intervention. So what did we do? First, it is very important that everybody understands the process within the ministry and the state government, within health department specifically. What is PIP, which is program implementation plan, what is ROP, which is approved by Ministry of Health and Family Welfare, the record of proceeding, how does NPCC, the National Program Coordination Committee, and their importance. It is very important that when we try to influence budgeting, we need to understand the beauty of these processes and the importance of these processes. Along with it, it was very important to first chart out and map out what are the effective FMR codes. So when we started this whole process of identifying which are the FMR codes which relate to Anemia Mukt Bharat in total, and more specifically for SBCC or the demand generation, we ended up finding that there are 11 FMR codes available under the NHM template for Anemia Mukt Bharat, of which there are 42 minor heads available which relates to Anemia Mukt Bharat components. It ranges from procurement, ICBCC, testing, printing, incentives, and across. However, when we deep down to ICBCC, there are specific 16 minor heads available under NHM PIP framework, which can be used to leverage funds for Anemia Mukt Bharat, specifically for demand generation, which includes both activities as well as the printing. But before we started this whole process, it was important to know what was proposed in the previous year, what were the components prioritized in the previous year, and then accordingly, based on that, we support government to plan the next year PIP. So an ROP fact sheet was developed at state level where we mapped out what all funds have been approved by Ministry of Health and Family Welfare for Jharkhand in total, including the ICBCC components. While this fact sheet helped us to identify what was available, what is the gap, we identified that there was not a single fund proposed or approved for ICBCC for Anemia Mukt Bharat. We also understand that 2019 and 20 was effectively the first PIP year for Anemia Mukt Bharat because it was launched in 2018, 14th of April. So it was the first, so largely the funds focused on the procurement and the supplies and the incentives. So the PIP 2020 and 21 was the base year where we really built upon that, okay, we have ensured the supplies and the funds to procure the IFA syrups and tablets, but what about the demand generation? That was also the time when we got support from the national level, that a lot of approved prototypes were available. So if we go to Anemia Mukt Bharat, a lot of range of products and materials are available, audio, video, print, games, which was a very important step, because having those prototypes is one of the first steps to ensure that we are able to even justify the need for ICBCC components and the funds. Of course, then material is just one step, but then there is need to plan activities on how to use those materials, how those materials will be transacted. So, for example, if there is a material called 4 Mantra book in the AMB dashboard, but then whether it is to be used by the students or it is to be used by the teachers, whether we have to print it for all schools or all classes or all students, there were a lot of discussions that happened, because even how to transact these materials. It was also found that for few of the things we don't even have a costed template or a cost norm. For example, while Sid also explained the importance of the T3 camp as a strategy to increase demand generation. So there was a letter from ministry, and the guidelines also talk about the test-free talk camps, but then we didn't had any norms, prototypes, cost norms, how much to fund for a T3 camp, how does the T3 camp looks, and we are thankful that from national level we got those cost norms available. We also got the prototypes on how a T3 camp in physical status looks like, what are the templates of banners, chairs, tables, the branding of the T3 camp. These things, when available from national government, it really helps the state government to plan properly based on the denominators and then propose for funding. So based on all these materials, there were some of the materials for which we were not aware of the costing, and also using the experience of states previous years tenders and all, that costed template was developed. And of course, simultaneously, a lot of capacity building effort was gone to build the capacities of the consultants and the team at the state level, as well as with the partners. So we at national level, we partnered with National Center of Excellence for Diet, who supported in capacity building, understanding. A lot of consultants are new, so it is important for them to understand what exactly is PIP and how it is the whole process. Meanwhile, focusing on this technical aspect, it was very important to have an intra-departmental convergence. Of course, it was led by the government, especially the Deputy Director Child Health, the Nodal Officer, and with support of the whole NHM team, the whole advocacy, as well as in Jharkhand, there is a consortium of partners of UNICEF, IP, Global, WeCan, and Evidence Action 3. All three partners work together along with NHM to provide those supports and gap filling. With PIP, it is also important to prepare justifications because we know there are budget ceiling, there are resource envelope for every state which is provided by ministry, and it is important to understand these terminologies and its importance, and then try to find out a way on how we can avoid unnecessary cuts. With ICBCC, one thing that we found last year, that while we propose a lot of funds, say for example folk shows or radio spots or television spots, but a lot of times these things are not approved for program wise, but they are approved as a pooled kitty for a section. So ICBCC for child health or maternal health. However, the risk is that when it goes as a pooled head and not tagged to a program, it is very difficult to ensure that whether the fund is actually used for the program, or at least partial or some percent of the program fund is used for the program. For example, Anemia Mukt Bharat is difficult. However, if we can provide some prototypes like scripts, audio, video, the whole material of AMB dashboard which is available, having prototypes I'm sure does help to some extent to ensure that the funds even in the pooled kitty are available for the program. Next step also is that even after getting the funds available and approved by ministry, there is a step called development of district resource envelope, the DREs. Now this DRE is one of the most important tool because through these DREs, government reserves some funds for state level activities largely related to printing and some mass media, but rest all the funds are diverted to the states in a decentralized manner so that the funds are used. And it is very important that there is a denominator based planning rather than the funds being divided in equally among all the states, all the districts. For example, there are 24 districts. So it is good that the state does a denominator based planning, and then the funds are sent to districts based on that. Next slide, please. So this is just one example that we are thankful to Ministry of Health and the national level support that during 2019 Poshan Ma, Jharkhand saw that the T3 camps were one of the most popular activities as part of the Poshan Ma. On nearly all districts held these camps in every blocks and villages level. These data is also available from the Poshan Jan Andolan dashboard. This one experience taught us that if we can provide template, we can provide all the information, detailed out budget, or the guideline screenshot that I have pulled it here. It also mentioned on specific activities, like if you want to organize T3, how much to be funded for the camp, how much to be funded for the supplies and other things. So if you give an idea, you provide all the prototypes, you also demonstrate that districts are able to roll out these programs, and which is also aided with specific cost norms, budgets, FMRs. It shows that it works. So as much as clarity we provide to the state government, and similarly by state government to district level, it has shown that activities have been able to run out well in the field, and it has been completed. The activities has been completed in a stipulated time. Next slide. So while I was talking to it, this slide summarizes that what Jharkhand received as part of their ICBCC budget. If you see the left-hand side circle, there was no budget available for ICBCC or the demand generation component under the AMB budget. However, with advocacy, availability of cost norms, availability of templates, availability of materials, Jharkhand could leverage at least 5% of their total budget for demand generation. In the table below, you can see that last year we received around 35 crores for Anemia Mukt Bharat, while this year there was a total jump of around 26% more, and now this year we have received 44 crores. This is a total budget for Anemia Mukt Bharat, but if we go into deep dive into the SBCC or the demand generation, then nearly 2.6 crore, which is 5% of the budget, is available dedicated to AMB demand generation. While here we also acknowledge that there may be some more funds available through the pooled kitty and other things, but in this slide what we have shown is the specific AMB dedicated demand generation funds available under the NHMROP. However, the question is it adequate? We really don't know. It is a very dynamic process, and as we'll move ahead, we'll realize that whether this fund is adequate or not. I'm sure we need more funds, but as and when we strengthen the supply chain, as and when we strengthen the demand, automatically it becomes more easier for the state governments to budget, because otherwise we all know that there is a component of resource envelope ceiling, And here I am also, there is one point that I want to share is that this is all which is available from ministry. While we also acknowledge that there are funds sometimes available from the state kitty as well, from health department, as well as what Deepika shared, that funds are also available under Poshan Abhiyan through DWCD. Next slide.
Preetu, request you to move to
Yes,
your key points really quickly. Yes, thank you.
This just shows the budget breakup. We can move to the next slide. Here, just the one point that Jharkhand is thankful to Ministry of Health and Family Welfare that we proposed for around 2.64 crore and 100% was approved by Ministry. So it clearly shows that this program and demand generation component of AMB is a very integral component for even for Ministry of Health and Family Welfare. The slide just shows a comparison that the gap between what is required and what is proposed has been thinned down to around 11% this year. While if we see the gap of what was proposed by the state government and what was approved is less than 2%. So nearly what state prioritize, Anemia Mukt Bharat being a very important program for Ministry of Health and Family Welfare, largely it gets approved. And this gives a very strong signal to the state government also that most of the things are getting approved and its implementation and rollout is important. Next slide would be my last slide, please. Thank you. So what were the key lessons? Some of the key lessons is that it is important that we have a round-year engagement with NHM. Working closely with partners helps to avoid duplication and ensure that the advocacy with one voice goes on. Understanding the NHM PIP and the whole process is very, very important. Partnership support is important. Having dedicated human resource enables the whole process because then the continuous hand-holding support is always available. National support is certainly very important to get the prototypes, tools, training, norms clarity. In Jharkhand, what we did that the whole AMB package was then translated into 5 regional languages, which is Hosadri, Santhali, Nagpuri, and Mundari. So all videos, posters were translated because Hindi is not spoken in all the districts, and for wider dissemination with equity, it was felt that the whole package needs to be in the local language. Certainly now tracking and ensuring the disbursement of the fund is important, and it is important to build the capacity of IEC division so that they can understand and prioritize the components for AMB and then ensure that these are well reflected in their own internal plan. Next step would be to ensure that these funds are disbursed. Some challenges are there due to COVID, but however, we have to also understand that supplementary PIP period usually starts from September. So this whole financing exercise also helped us to know that what are the further gaps and where we can really budget for the supplementary PIP. That is all from my side. Thank you.
Thank you so much, Preetu. This was extremely detailed and it just goes on to represent how important it is and what kind of effort is required from center to state translation and making sure that the budgets are adequate and they are being deployed well, and you're bridging the gap in terms of through informed knowledge. You're bridging the gap between what is required and what gets deployed. Just one question for you in light of the time. Now it's time for supplementary PIP coming in September. So what is it that you're learning and how is it that you're preparing for the upcoming budget?
So we have prepared a detailed fact sheet on comparing what all funds are available, what was approved, what was not approved, and through which we have also identified which are the components which were expected by MOHFW but have not been proposed. For example, Anemia Mukt Bharat guidelines talks about establishing a center of excellence for Anemia Mukt Bharat, or there are provisions that a ministry can also provide funds for transportation and other things. We are also checking on the PIPs and the ROPs of other states to learn what are the best practices, and those learnings will help us to prepare a better version of a supplementary PIP. And of course, this has to be done taking into context what is possible and what is not in present COVID context. Thank you.
All right. Thank you so much, Preetu. That brings us to the end of the panel 1, requesting that we move to the panel 2, which focuses on implementation science. So we've spoken about budgets and resources, and the other part is really using science to inform content, to understand barriers, and making sure that the programs are designed in a way that the barriers are being addressed. So thank you so much. First, I have Dr. Rajiv Rimal, and he is Professor and Chair of Department of Health, Behaviors and Society at the Johns Hopkins University. I know it is really, really early for you. So thank you so much, Rajiv, for joining. He's working on what we call the Rani project in Orissa, and he's going to be sharing his knowledge from coming in from that project. So over to you, Dr. Rajiv, and not taking too much of time here.
Thank you, Archana ji, and good afternoon to everybody on the presentation panel this afternoon. So I'm going to be talking about the Rani project. The Rani project, Rani, the term stands for Reduction in Anemia Through Normative Innovations. And I also want to acknowledge our partners, IPE Global, Government of Odisha, particularly the Odisha Livelihood Mission, and DCORE in Bhubaneswar. Next slide, please. The Rani project is a 3-year demand-side intervention that is currently being run in 2 blocks, Atmalik and Kishore Nagar blocks in Angul district in Odisha. It's a randomized trial that is really exciting because we are asking, I think for the very first time, whether a field intervention can actually change social norms, and whether those social norms can in turn change behaviors as well as outcomes through hemoglobin assessments to reduce anemia. Like I said, it's a 3-year project. We are currently just finishing our midterm assessments. The project will go on until February of 2020. And I just want to acknowledge our funders, the Bill and Melinda Gates Foundation, as well as my program officers. Next slide, please. So before we talk about this project, I just wanted to pause for a minute because I will be using this term social norms quite a bit. I wanted to pause for a minute to make sure that we are all on the same page when it comes to the definition of social, because that's a term that is used a lot in the behavior change world. And I think it means different things to different people. So in this project, we use the term social norms in 3 particular ways. Generally, it is the extent to which people's attitudes and behaviors are driven by what others expect them to do. In the literature, there are 3 types of norms. One is what we call descriptive norms. Descriptive norms are people's beliefs about how prevalent a particular behavior is. So, do women in my village take IFA tablets? How many of them do so? How popular is this behavior? That's what we mean by descriptive norms. Injunctive norms are beliefs about what others expect me to do. So do I feel pressure to conform? Will I be punished if I do not conform? And then collective norms are what others actually do. So the descriptive and injunctive norms speak to people's perceptions, and collective norms speak to actual prevalence of behaviors in one's community. Now, from a theoretical perspective, I think what's interesting about social norms is that, as is depicted in that cartoon, all of us think of ourselves as nonconformists, even though we are all wearing the same t-shirt. It's not very cool to say that you are influenced by other people, because after all, we are independent human beings. Next slide, please. In the Rani project, we use a particular theory. The theory is called the theory of normative social behavior. And basically what it says is that the influence of social norms, which is the box that you see on your left. So social norms affect behaviors. And in this case, the behaviors of interest to us are IFA, iron folic acid consumption, as well as diversity in one's diet. So the idea here is that social norms will affect these behaviors, but not in a very uniform way. It's not like, you just change norms and magically behaviors will follow. You change norms and behaviors will follow if a number of things also happen. And I think that's a critical part of what I'm going to be talking about. So those things are, for example, knowledge. So people also need to know why they are being asked to do what they're being asked to do. Their perceptions of risk, their self-efficacy to act, their expectations about the benefits of taking that, engaging in the particular behavior, et cetera, et cetera. I don't need to go into all of those factors. But so what the Rani project is trying to do is to A, change norms, and B, change these, what we call moderators, that in turn affect norms. So it's a multi-pronged approach. Our outcomes are actual adherence to IFA tablets and dietary diversity. But our ultimate outcome is hemoglobin count obtained through finger pricks. And so that is pretty interesting in and of itself. But for me, what is even more interesting is that what happens after that. So if we, in fact, reduce anemia as measured through hemoglobin count, could we see changes in women's mental health? There is literature showing that depression, for example, is associated with anemia. So the question is, if we reduce anemia, will depression also get reduced? There's also a lot of literature showing that the brain functioning is the first to go and the last to get repleted when we start taking iron. So, and that has huge implications for women's cognitive functioning. Because anemia is associated with weakness and physical activity, we are also interested in women's work capacity. So does work capacity improve as a result of reductions in anemia? And then lastly, do all of these things also affect women's quality of life? Next slide, please. So I don't have time to go into all of the different components of the intervention, but let me just highlight the key features of what we are doing on the ground. We work very closely with self-help group members in the communities, and we conduct participatory learning sessions, as the picture there shows, which is very hands-on efforts to educate people about the importance of anemia, their perceptions of risk, and so forth. These are very hands-on in the sense that, to illustrate ideas of weakness and feeling weak. We have women play tug of war between themselves. And these learning sessions are really designed to be quite hands-on. We also have what we call Rani Com videos. These are short 4 to 5 minute videos that were shot, edited entirely in location that illustrate different groups. So they target adolescent women, women of reproductive age, men, as well as mothers-in-law. And each video is a short story of overcoming physical weakness by changing one's diet, by consuming IFA tablets, and illustrating that through a storyline. The biggest hit so far has been the third element, which is hemoglobin testing. So every month in the 130 villages where we work, we take 15 women and do their hemoglobin tests in the community. And we post their results anonymously. We post their results on the community boards and then talk about what those results mean. We provide feedback in terms of, they get either a green card, a yellow card, orange card, or a red card, depending on their hemoglobin reading. So a green card if you're anemia free, if you've got 12 grams per deciliter or more. Yellow if you're mildly anemic, orange if you're highly anemic, and then red if you're severely anemic, in which case we link you with care to make sure that you're taken care of right away. Then over time, we display the results of the hemoglobin tests at the community level, and we compare what we call, here's where you were 6 months ago, here's where you are today. So that's what we call ipsative feedback. So we provide feedback on the progress over time at the community level. And then we also do social norms comparisons. We say, so here's your community today, the average level of hemoglobin in your community, compared to 2 of your neighboring communities and how they are doing. So there's a friendly competition among communities in the hemoglobin levels. And then lastly, we provide aspirational feedback, which is, here's where you are today compared to where you want to be 6 months from now, a year from now. We also share the village level hemoglobin results and comparisons with the local government, with the medical system. And this has created an enormous amount of pressure to have testing available. And also women are now going up to the Anganwadi workers, to ASHAs and others, and demanding IFA tablets be provided to them. And what this has done is, quite unexpectedly, I think, it has provided a sense of precision to something that was very vague. So yes, I felt weak. I didn't really know what it was all about. From that kind of thinking to, oh my gosh, I now have a reading of 10.3. And last month I had a reading of 9.7. And so it's given this sense of empowerment and I think precision to women in interpreting their own hemoglobin levels. Next slide, please. I wanted to share with you where we are in the timeline of the project. So we have just completed the midline assessments, and I'm here to share with you some very preliminary results from the midline assessment. And we will be conducting an endline evaluation early in 2021. Next slide, please. So based on our roughly 5.5 months of intervention activities on the ground, in the treatment and control communities, we have yet to see movement on hemoglobin count. So we have not seen changes in hemoglobin yet. We hope we will. And if we do not, we will be very eager to learn why not. But basically what this is showing is that on average, we have about 11.7, 11.8 grams per deciliter in the treatment group at baseline, and about the same, there's a slight increase, but about the same in the, at midline in the treatment group. And similarly in the control group, that's fairly flat to date. Let's go to the next slide, please. And then now when we look at IFA consumption in the last 7 days, there are huge differences in just these short 5.5 months. So on the left panel at baseline, from an average of about 0.4, we now have about 1.6 tablets in the last 7 days. And in the control group, those numbers have remained flat. So there's been no change in the control group, and there's been a fairly significant improvement in the treatment group. Next slide, please. This shows compliance with IFA guidelines. So the IFA guidelines are that if you are pregnant, you take 1 pill every day. If you're not pregnant, you take 1 pill every week. And so compliance here at baseline in the treatment community, it was only 4%. That has now moved to 33%. In the control community, it was 5%, and that has remained flat at 5%. So compliance is definitely improving in the treatment group, but not, it's remaining flat in the control group. Next slide, please. We also asked women, what are your intentions to consume IFA regularly in the next week? Here too, we see very similar results. So there is a significant improvement from baseline to midline in the treatment community. There's a pretty much of a flat line in the control community. Next slide, please. In terms of norms, we see that, again, descriptive norms, this is the perceived prevalence of what's happening in my community. Descriptive norms have improved quite dramatically in the treatment group. They've gone up a little bit in the control group, but as you can see, the movement in the treatment group is significantly better or higher. Next slide, please. Injunctive norms are perceptions of people's approval for taking IFA tablets. And in this case, so we see very similar patterns that the changes in the injunctive norms are significantly higher in the treatment group than in the control group. I should also mention that because of COVID-19, we temporarily halted all activities, and now we are revamping, about to launch our Mhealth Intervention that is going to be conducted within the treatment arm, where we are developing a soap opera-based intervention following entertainment education principles. And within the treatment arm, we are further randomizing women to either receive an entertainment education-based story to promote IFA consumption, or in the control arm, we are doing another intervention to reduce bystander witnessing or to increase interventions for bystander observations of violence against women. So we're using that as a control group and IFA tablet consumption as the treatment group. I should also mention that we have a very robust, what we call the RPM system, which is a rapid performance monitoring, which happens in real time, that allows us to see on a dashboard how many activities are happening in which communities, and we're able to take corrective action as needed. Next slide, please. I want to end by saying that one of the outcomes of this intervention so far is that we have pretty much depleted all the dormant IFA supply in the 2 blocks where we work. In fact, we only have a month-and-a-half supply left as I speak, and we are working very diligently with the government, with our funders, to see what we can do to replenish the supply, because obviously we do not want to run a demand side generation project when the supply isn't there. Basically right now we have taken supply that was dormant, not being used in other blocks, and brought it to the treatment communities to make sure that at least the demand generation activities are running in places where there are supplies. And so this is a challenge that we are beginning to confront at the moment. So let me pause there. I want to thank you for listening, and I'm happy to take questions.
Thank you so much, Dr. Rajiv. That was fabulous and so encouraging to see those results. In the question and answer chat box, as well as the other, there are some questions for you. I don't want you to go away because there are other presentations as well, and towards the end we will ask you some questions that I have, but there are other questions if you want to look at them live. Requesting the bio as well as presentation from Daya to show up, and also requesting my other panelists to keep it to their time limit, please. I want to make sure that we are answering all questions from our participants because they are coming in. So very quickly moving to Daya. He is coming on next. He is the C4D officer from UNICEF UP. Again, a thorough expert with extensive experience, not only on health and nutrition, and he's worked also on other programs like polio eradication, as well as measles, rubella, RI work that goes on so extensively in the state of UP beyond health and nutrition. Not taking too much of time, and over to you, Daya.
Thank you, Archana, for giving me the opportunity. Actually, I'm going to present the communication plan. What is the AMB communication plan, which is approved by Ministry, thanks to Ministry MHFW as well as the state government, who has submitted the communication plan for the AMB, specific for AMB, because in the other state, the AMB demand generation is incorporated in the Jan Andolan plan. So I think that Uttar Pradesh is the first state who received the fund from the ministry. So I would like to thank Dr. Sheila Dev and her team and the advocacy by the Rachana and Sid to got the state fund around 9 crore 32 lakhs for the demand generation. So we have, as you know, the Uttar Pradesh has the large cohort, 33 million children from 0 to 6 months from the 19 year, and 14 million the women who are the targets. So next slide, please. So initially we have just get the sense ki what is the barrier at the individual level, societal level, and the system level. So as you know, the low awareness and lack of critical information related to the benefit, risk perceptions, social norms, as Dr. Rajiv told, and the sectoral level, the different barrier we have realized, and the systemic level we have realized the different department will not converge at the different level. So they think AMB is a health department responsibility and the target group in the schools. So it was a challenge for us and challenge for the state. Thanks to state to next slide, please. Thanks to actually the whole campaign proposal has been established when the Dr. Sheila Dev came to the Uttar Pradesh and organized a state level AMB orientation for all the department, the sectoral lead from the district. They have participated over there, and in the month of January 19. After that, we have developed a communication strategy with the partner of the partner like the TSU supported by GATE, NI, Plan, Alive and Thrive, and the Piramal Foundation. So we have developed a good plan and submitted to the NHM, and thanks to the NHM mission director, he has approved and submitted to the ministry. So when the plan has approved, principally ministry has approved 18 crore rupees for the communication plan only to demand generation for AMB. And then when the plan has approved, we have organized a meeting with the principal secretary when we call all the ministry, all the line department partners who have presented their role and responsibility, and clear guideline has given by the Secretary Health and Family Welfare. So what is going to happen for the adolescent? What is going to happen for the women and women? So the campaign has launched in the month of January with the all preparatory work. We have organized the several round of the training for the partners as well as the other stakeholders. What would be their responsibility? Next slide, please. So with the approved communication strategy, we have defined each and every department role, like the Panchayat Raj department. They're supposed to work with the community, so women can mobilize to the BHND centers, and what with their role as a pradhan, and then department UPSRLM has played great role through their SSGs members, because Uttar Pradesh has a very vast network of SSG in 52 districts out of 75. And the same time, the youth network like NSS, Scout Guide, and the health department, of course, they are the nodal, and they have designated one nodal person each and every district who can coordinate with the development partners. And in the initial stage, we have organized several partner meeting where the all development partner who are working in the different districts, they have already designated their role and responsibility, how they are going to support in planning, implementation, as well as the monitoring. So, and women and child development department, education department, who have the major role, and 33 million children is belonging to the education department from primary school to the colleges. So these convergence has happened at the state level as well as the district level. Next slide, please. So we have, as I told, we have organized several planning steps at the state level, like launch, mass media. Mass media intervention is taken care by the CFAR, supported by Gates Foundation. Social media, our colleagues from the CAP section, along with the CFAR. And then and one more thing I would like to highlight, that whatever the material available at the dashboard, we have adopted as per our requirement, and mostly we have adopted from the AMB dashboard, and somehow we have adopted from the local need also. So material is available, there is no expenses over the materials. So we have developed the plan as per the budget, and then then district level activities. So the major change has happened as a learning we can get for the other state also. The DTFI, District Task Force Meeting under district magistrates, where all development partners, line department like education, PRI, ICDS, they come under the one roof, and they have share their plan and role and responsibility. So, and the district level, they have organized the trainings also, sensitization meeting, and the media also. Media has played a great role, and they have published several articles for the demand generation. It's great buzz. And the school level intervention, and same time for the women and the community level intervention we have planned and implemented through the health department. Next, please. So this, as I told, the district level orientation is really very critical, and the district task force meeting needs to be organized properly, and we have organized the district level task force meeting under the facilitated by the CMO and the district nodal officers, where all the health departments and partners, IC materials, plans, and whatever the plan shared by the state NHM, it has been implemented at the district level by these partners as well, led by the health department. Next, please. So, and one more thing we have facilitated through NHM, the school need to be organized 4-week activities where children can engage. The first week, the smart artist type, some thematic posters competitions, and the other engagement plan we have submitted to the schools, oriented to the school teachers in the different training, so they can engage children on the different aspects of the anemia. And the second week also we have developed some activities, and these activities has been reported by the education department. So now they have realized that this is not the only health department program, this is the education department. Same education department need to participate in the same wavelength. And the same time we have also developed the third and fourth week activity. So these activity has given some task to the students, and they have engaged very well, and teacher has taken the role, and they have reported to the health department. So this mechanism has given the idea how the different department, particularly the education department, engage with this anemia activities. Next, please. So these are the materials they have used, which is available on the AMB dashboard. So and these are the activity we have defined for the mobilization, advocacy, as well as the community level, how they are going to mobilize their children through the schools and UPSRLM, PRI, NSS, Scout Guide, and YKS. Next slide, please. For the pregnant women, we have proposed for the T3 camps and the activities before the T3 camp by the PRI, as well as the Anganwadi, ASAs, and the ANM, and to mobilize the pregnant women, given some idea due to the COVID, because it was planned in the month of March, due to COVID it has not happened. So this activity has been postponed. So maybe in this scenario we are going to just rechange the things, how we are going to implement through this new COVID scenario. So but we have planned in the activities prior to the T3 camp, the mobilization activity led by PRI and ANM and other FLWs, and then organize the T3 camp, and after that the how to organize the IPC component for these women. Next, please. So for that, we have organized the first week activity, second week activity, and third week. This is the campaign where we have given ideas to how to build the momentum in the community also through different FLWs as well as the PRI and the youth network to mobilize the community towards the AMB campaigns. So this is the plan which is going to implement maybe after this up to in this Poshan Abhiyan month of September, because due to COVID we have not implemented this IPC intervention, because as per the guideline we cannot go to house, that's why this has not happened. Next, please. So this is the activity we have already planned, and budget has been already allocated to the district from the NHM, allocated for the AMB campaigns. The first week activity, mobilization activity, and the focus group discussion during the T3 camps, and the twice focus counseling and during the third week. Next slide, please. Yes, so all the aspects we have completed in this campaign. The fourth steps was the monitoring by the system, where we have included all the partners wherever they are working, like 25 districts led by the TSU, and 7 districts led by the Piramal. Plan has designated 1 district. CFAR has supported in the across states. UNICEF SMNet has supported in 60 districts to plan, monitor, and given the feedback. So Poshan Abhiyan, as the biannual, we have planned how we are planning the Poshan Pakhwada and Poshan Ma, these activity, and then the AMB quarterly monitoring plan to, and it is chaired by the Secretary, Medical Officer, and the Health and Family Welfare Officers. State level, we have planned the State Nodal Officer led by NHM to monitor the activity, review the activity, and district level monthly review meeting chaired by the district magistrate. So now this intervention has given the buzz to the community, how the other department, line department, particularly education department, youth need to be engaged for the social mobilization and create demand from the community who can come to the center for the IFA tablets. I think this is the last slide. Okay, thanks.
Thank you so much.
Any question.
Yeah, thank you so much there. And, while Rajiv spoke about social norms, you've spoken about implementation at the last mile, including community mobilization, as well as reviews and monitoring, which is so critical at every step. So don't go away. We'll have Pawan deliver the last part of the presentation. He focuses on experimentation, and then I will have questions from to all the panelists as well. So requesting Pawan to join us, and Pawan is Director for Center for Social and Behavior Change. He is leading initiative to set up India's first nudge unit, which is in partnership with Niti Aayog. He is he's studied at the Harvard Law School and is a doctorate in sociology. Are leading the initiative to set up India's nudge unit with Niti Aayog, and you've studied at the Harvard School, and you're also a doctorate in sociology. So over to you, Pawan, in terms of speaking on your pet subject on experimentation.
Thank you so much. It's such a pleasure and such an honor to be among such distinguished experts and guests who have presented absolutely fascinating insights into how one might address this really, really challenging problem that Indian society faces. At the very outset, one caveat that I would like to place is that our work, the kind of work that we do, is somewhat similar to the kind of work that Rajiv presented. Rajiv does field experiments where he went and he tested these really fascinating insights on social norms, norm nudging. It reminds me of the work that Christina Bicchieri has done on empirical expectations and normative expectations. So that framework is tremendous. And Rajiv, at some point, I should explain to you how we applied the same framework in designing the COVID campaign for Niti Aayog. But returning to anemia, a couple of sort of preliminary thoughts that I wanted to share. The first one is that we do lab in the field kind of work where we test intervention ideas by taking a lab into the field. It's not a real sort of revealed preferences as such in terms of whether anemia has actually reduced. This is the work that Rajiv has done by pinpricks and measuring hemoglobin, etc. But there are some proximal outcomes that can be measured which tell us whether certain kinds of behavioral interventions are working or not. That's the first idea. The second idea that I would like to place before you is this broader idea of scarcity and how scarcity needs to be thought through very carefully. We have to be mindful of a couple of types of scarcity. I mean, this is the borrowing from the great work of Senthil Mullainathan and Eldar Shafir and so on. So there are different kinds of scarcity that pregnant women face. The scarcity of time, the scarcity of resources, the scarcity in terms of scarcity that's caused by cognitive loads, right? I mean, your brain, if you were to liken it to some kind of a processor, if it is already occupied by anxieties and fears, I mean, the pandemic is a great source of uncertainty, and it's likely to impose a tremendous amount of anxiety and fear on people. So that's likely to keep your mind occupied. So the question then is the mind able to make decisions which are appropriate to one's health? And engaging in practices which reduce anemia then become one of those sets of behaviors that you would hope to accomplish despite all these constraints that people face. So the first big sort of major idea that I would like to place before you is this idea of scarcity. And second big idea that as a behavioral science group that I would like to place before you is this whole business of systems 1 and systems 2. Systems 1 being instinctive, very quick kind of decision making that human beings take, and whereas the systems 2 is a more deliberative, slow process and so on. And given scarcity and given the cognitive loads that pregnant women are likely to face, how do we then find pathways to reach their minds and get them to act in a manner that is appropriate for their health? So, I mean, if you can go to the next slide, I just want to quickly describe the process that we use in designing our behavioral interventions. So, unlike typical field experiment groups like JPAL or what I imagine Raj's group also does, we also are a qualitative. We just don't do experiments, but we do qualitative work. We go out into the field, we talk to people, we have conversations, we do pre-experimental ethnography. And this is what we mean by the defined circle there, where we start off with the original challenge, which is to reduce anemia, but then we just sort of pick up a particular method. And that method is, okay, so we will try and accomplish this by increasing IFAP uptake, right? So that's the defined phase. Then the diagnose phase is where the qualitative work happens on the field, and we basically try to map out all the barriers to change and all the facilitators which can potentially help us change in the right direction. And then we come back with all this qualitative data into our center, and that's where the design process happens. This is where we come up with, we have a couple of designers. This is where we come up with potential behavioral interventions. And by behavioral interventions, I would also like to make an important distinction, and that is, it's not just communication strategy, but it's also potentially three-dimensional artifactual kind of interventions which can change behavior. And then we take it into sort of the testing phase where we conduct these lab in the field experiments, which are oftentimes quick and dirty, and we try to get a semblance of a purchase of causality, which allows us to say, hey, I mean, this intervention is working really well, and we can take it forward for scaling, or which we can later test in the field. Next slide, please. So next slide, please. Yeah, so let me go straight into some of the interventions that my center has come up with. And maybe, you know, I can stop right after this slide, because the slide in itself presents a couple of options which we found really, really fascinating. The first one is the food equivalency chart, right? I mean, to try and explain what one means, what one even means by the consumption of iron is a bit of a challenge. I mean, the first question is, why should we eat iron? Why should we consume iron? What does iron do? Our qualitative interviews, you know, bring up these questions from subjects. They want to know why should we even consume iron? What does iron do? And the idea that spinach can even carry iron seems somewhat metaphysical. So, I mean, you got to wade through these very difficult conceptual frameworks to even give a semblance of an idea of what the iron pill does, right? I mean, you can't go into the entire science of it. How do you make the science of the consumption of iron pill salient to the potential subjects is something that we hope to at least partially address in this food equivalency image that we created. The second intervention that we came up with was this job aid. It's really a sort of a laminated card. It's a counseling card, which frontline workers can carry to subjects, and you know, it helps them talk about a couple of key concepts. The first thing that the card helps the frontline worker talk about is the management of side effects. Iron pills, you know, a lot of my friends who have undergone pregnancy tell me that they're almost noxious. They produce these very frightening effects and so on. Now, there's a brilliant insight that has come up in some of the discussions that we had with Dr. Paul at Niti Aayog. He said, you know, people, when they take these iron pills, it exacerbates their feeling of illness. You take an iron pill, it makes you noxious, it makes you want to puke, and so on and so forth. And Dr. Paul said, why don't you twist this experience on its heels and tell people that these are actually signs that the tablet is working, and it's a good thing, right? So this inverse relationship between an unpleasant experience and positive health is something that can be potentially leveraged. And this is an idea that, you know, we hope to capture in this particular image. And this is an idea that has been used successfully by Dettol, for instance. Dettol has an obnoxious smell, but that indicates to people who use Dettol that Dettol is actually working. If you give it a fragrant smell, people are going to be turned away from Dettol. So in some sense, the unpleasantness is a costly signal of the experience of success in engaging with the product. That's the first thing. The second thing that the counseling card does is it also talks about the regularity. I mean, you know, you got to specify at what time should you take the tablet. So ideally, I mean, you know, you want to internalize the noxiousness, the bad experience at a time when you're asleep. So, you know, bedtime is a good time for you to take the tablet. And this is what the counseling card image portrays there. The other nice thing about the counseling card is that it reduces the sort of the fumbling that a frontline worker might experience in trying to explain IFA to a potential subject. It standardizes it, it makes it routinized, it's you know, well rehearsed out, and it gives a certain kind of a textual authenticity to the script that is being delivered to the subjects. The third intervention is a fairly straightforward one that we created. It's a testimonial video, which basically has somebody drawn from within the proximate community who's talking about the excellences of taking IFA pills and so on. that's another sort of intervention that we design. The fourth intervention, which we feel the most excited about, is the calendar, right? I mean, this is a goal tracking calendar. It has a couple of elements. And so each pregnant woman is supposed to receive this particular calendar. And I don't know if you can see clearly here, there are images of beautiful babies, or rather charming babies, attractive babies, that you can scratch off. And then that activity then becomes a reminder that you have to take your IFA pill, right? So it's an interesting idea in that it produces a sort of a micro incentive for a person to look forward to on a daily basis. Now, I mean, goal tracking devices, calendars are fascinating pieces of technology. I mean, you and I take it for granted, but think about the times when the calendar first came into existence and got adopted in the history of ideas in science and technology. And that's exactly what we're trying to do in certain communities which have not been exposed to calendars. So there's something really profound about taking a calendar and making it a technology which allows people to track their goals of taking pills by hitching on to the periodicity of a particular date or whatever, and allowing them to remember that they need to take their pills. Let me not talk too much about the IVR reminder calls. I do believe that they were a bit of a failure. Let me go straight into the next slide. Can we have the next slide, please? These are some quick and dirty results that we found from this study. In terms of what is the best strategy to cope with side effects, we found that the counseling card produced a significant advantage over the control, as you can see from the graph. Most of these observations are self-reported, and they don't have the same validity as Rajiv's study. I mean, he actually went and pricked people and drew blood and measured hemoglobin. That's the ideal way to do it. But these are lab in the field kinds of work. So the calendar findings also produced some really encouraging results that you can see from here. There was a 14% greater likelihood to adhere to the proxy behavior. I mean, so the proxy behavior here is somewhat better than self-reported behavior because there's a bit of a costliness involved in committing to making a phone call to say that you have actually adhered to the regimen. Let me pause here, and then I'm happy to take. So this is sort of the spectrum of interventions that we attempted. These are behavioral interventions that we attempted. Since we did not have the luxury of time to do one single, shall we say, intervention over a long period of time, which is really the essence of field experiments, because we are a lab in the field kind of a setup, we were able to experiment with a wider portfolio of interventions. And that could be an interesting way to sort of also mitigate the risk that some of these interventions may fail. And there are also, I think, labs in the field kinds of studies are also good ways to animate future field studies of the kind that Rajiv is doing. Let me pause and stop there, Archana.
So thank you so much for that, Pawan. Just a quick question for you, and then I will have one question each for Daya and Rajiv. And the participants have been writing their questions. They are being answered. Rajiv, thank you so much for answering all the questions. And I would encourage the other panelists as well to look at the Q&A as well as the chat box to answer all the questions. So quick question, and this is going to be almost like a fire side
Sure.
chat, like I'm firing the questions and give me a quick answer. Why do you think experiments are so important in building credibility of intervention ideas? You've spoken a lot about experimentation.
So, Archana, I mean, one of the times when we actually know that experiments are so critical is really during the time of the pandemic. Take, for instance, the kind of faith that people laid in hydroxychloroquine. All that we had were anecdotal pieces of evidence, observational evidence that it's working. You ignore the possibility that the person is automatically getting cured. What experiments allow us to do is to overcome this problem of confounds. They give us a tremendous purchase of the causation, of the causality between a proposed intervention and the effect and the desired effect. So in some sense, it's a very powerful technique of establishing the causal relationship between the intervention that we spend money on and the result that we get. So in some sense, it also increases accountability in the system by proposing policy interventions based on experiments rather than purely on qualitative or on observational studies, provided, of course, we have the time and the luxury to do so.
Thank you so much, Pavan. And one last question, and then I'm going to hand over to Rachna. She can do the closing, and we will, restrict participant questions to chat box only. Rajiv, if you can come back on video, I'm asking you this question because this has also showed up in terms of chat. Why did you focus on IFA supplementation and not on diet diversity? Because that's a very critical component as well. And was it hard, and is IFA simpler?
Well, I think IFA, one of the main reason is that, for a project like this that has not really been tried before in the field with this kind of scale, we tried to focus on something that could bring about change rapidly. And, for a year and a half that we were going to be on the ground, we really did not imagine that focusing on dietary diversity was going to bring us the outcome that we were seeking. And also what we have learned on the field, because this issue also came up in the question, was that dietary diversity is much more seasonally driven than it is normatively driven. And we are kind of beholden to what is available in the villages. So that was, I think, going down that route, I think was going to be a bit diluted in terms of the effectiveness of the intervention. So that's primarily why.
Thank you so much. And before I hand over to Rachna, can we have the AMB dashboard on that come up, please? The AMB dashboard will have all the presentations. Please make sure that you have, I know lots of people have asked for these presentations. Please make sure that you are accessing this resource, and fantastic learning for each one of us, including me, who is passionate about this subject and working extensively on nutrition, that I will keep referring to the presentation and reaching out to all the panelists for further questions that I may have. With that, I'm handing over to Rachna. Rachna, please go ahead and close the session today.
Thank you so much, Archana, for a fantastic moderation. With huge thanks to all the panelists, the amazing set of panelists, I would like us to take away, all the listeners and participants who are with us, I'd like us to take away the following on Anemia Mukt Bharat demand generation, especially for its acceleration and enhancement. First, for a successful demand generation program, the signs of social and behavior change has to be adhered. That came across very, very clearly from the Rani project to RISA, the targeted AMB campaign in UP, and the pilot trial by CSBC. All explain the same: understanding behavioral insights, barriers, enablers, making the right behavior change theory choice, and designing intervention accordingly is key to success. This requires time, but assures results. Dedication, expansion, continuation, and upscale of the intervention is the next step, which ensures equity and that all are reached and benefit from the program and not just a few. Now, this requires financial efficacy and planning. We pick up from the bank and from our portion with two different departments and ministries. They guided us on the process of engagement for ensuring right costing, budgeting, planning, approval, utilization, and reporting. The UP Insight, I thought, also reminded us the importance of leadership and governance to ensure monitoring and course correction with the high offices of government. Listening to all speakers, actually, I was reminded of one of my favorite book, The Vital Drop, which is on communication for polio eradication, published 12 years ago, 2008. It reminds us now more than before, I would say, that creating the right noise, beating the drum, and optics is very, very important in a social development program. People are consuming too much and too fast, whether digitally or otherwise. When programs like Anemia Mukt Bharat stand out in optics, in messages, in the materials, in outreach, which is regular, consistent with quality, actually difference will begin to be seen, perception will begin to change, and norms will begin to be formed. And finally, referring to the same book, I thought it's good to remind ourselves that demand generation program need not be rigid and written in stone, but must evolve to the new realities and context which COVID-19 has jolted us and really prepared us for. I'll end here with a call out that for AMB demand generation, the health system blocks are being worked on, which is governance, supplies of not just IFA, but all the communication products, the supply chain for that, the capacities of functionaries to be able to counsel. We did not talk about that, but it requires huge investment to be a great communicator in the field situation. The services, the skilled human resource pool, and finally the finances. I think regular investment in these blocks by the team of partners who's working and supporting Ministry of Health for AMB program will ensure sustainability and results and gains in the long run. Thank you, everyone. Let's talk anemia. Thanks, Archana. Thanks, everyone.
Thank you so much. Bye-bye. And with that, we're closing the session. Thanks a lot, Archana.
Thank you.
Thank you.
Thank you.